let's go and talk a little bit further down and talk about the diseases of the anterior pituitary. Now this is the, as I said, this takes up about 80% of the pituitary itself. And let's talk about this case. A 32-year-old woman comes to your office because of milk-like discharge for over 4 weeks. Her examination reveals galactorrhea, but it's otherwise normal. And otherwise normal, I mean she doesn't have any visual disturbances. She doesn't have you do an evaluation of the visual fields, and she has no bitemporal hemianopsia, right? So she doesn't have visual field cuts. So what is the next most appropriate tests in these patients? So they want a couple of the tests that you're going to do in this patient, and we're going to come back to this case. Just let me talk to you a little bit about galactorrhea first. So that's what this patient have, or the milk-like discharge was galactorrhea, and she has hyperprolactinemia. So hyperprolactinemia is an excess in prolactin. It presents in women with the syndrome of amenorrheal galactorrhea. So that's the typical, the amenorrheal galactorrhea syndrome is the one that is associated with hyperprolactinemia. In men, it mostly presents with hypogonadism. It is very rare in men to cause gynecomastia or galactorrhea. It usually causes hypogonadism. And in men, because it's usually a macroadenoma, in women it's usually a microadenoma, probably because we pick it up earlier, but in men it's usually a macroadenoma. It also more commonly presents with visual field cuts, bitemporal hemianopsia. So bitemporal hemianopsia is very uncommon in women, probably because they present earlier. Men, when they have this, the hyperprolactinemia, and they have the prolactinomas, they usually have bitemporal hemianopsia. Out of all the pituitary adenomas, the most common, this is the most common functional adenoma that we see. But there's other causes of hyperprolactinemia, right? Like stress and stimulation. So it's not only a prolactinoma that causes this, even though the prolactinoma is the most common functional adenoma. There's other things like stress, stimulation, drugs, especially dopamine inhibitors. Remember that prolactin is under constant inhibition from dopamine, and once you give a patient a dopamine blocker, right, if you block the dopamine, this patient develops prolactinemia and hyperprolactinemia and galactorrhea. So please remember that. So one of the first things we do in these patients when we go back to the patient that we just talked about, one of the things you got to do is get a good medical history from her, make sure she's not taking any of these medications. Now reserpine is an antihypertensive medication. We don't use it anymore, but that was one of the reasons it used to cause galactorrhea. And H2 blockers like cimetidine and stuff like that, they sometimes cause galactorrhea. And so forth. And then the third one that I want you to remember is hypothyroidism. Now, this is the issue. Usually prolactin is only under constant inhibition from dopamine. There is no enhancing factor under normal conditions. What happens in hypothyroidism, though, if you have primary hypothyroidism, remember your TSH goes up, right, from the pituitary, that does nothing, but your hypothalamic hormone also goes up, and this is called thyroid releasing hormone, or TRH, thyroid releasing hormone. And thyroid releasing hormone under normal conditions probably does nothing to prolactin, but if thyroid releasing hormone is very elevated, very increased at very high levels, then what usually happens is that it enhances prolactin, and you get hyperprolactinemia and galactorrhea. So one of the things we always rule out with galactorrhea is hypothyroidism. Very important that we check. The most easy way to do that is check a TSH and make sure it's normal. And then the fourth one, I didn't put down here, but I want you to remember, it's in your notes, it's very important, is pregnancy. Now, usually galactorrhea occurs after pregnancy. We all know that. It's not usually during pregnancy that we see that. But some patients, even in the second trimester, they develop a little bit of galactorrhea. So please remember, make sure you get a pregnancy test. So thyroid test to exclude primary hypothyroidism, get a good drug history to make sure the patient's not taking any medication that would block the dopamine secretion, and number 3, get a pregnancy test. That's the most important thing. If you exclude that, if you exclude all these basic categories, then you could check along with that a prolactin level to make sure that this is the prolactin levels are high, and if the prolactin levels are high, then it's likely to be a prolactinoma, the most common functioning adenoma in the pituitary. And then after that, what you do is you image the pituitary with an MRI to localize the adenoma in the pituitary, the prolactinoma. So the workup is to exclude drugs and hypothyroidism, exclude pregnancy. Then after this, we check prolactin levels, right? So now if we excluded everything else and we have high prolactin levels, it's a prolactinoma, right? And then we go to an MRI to localize it, to see how big it is, to get an idea of what is it, if it's causing any pressure phenomena and stuff like that. Treatment, always you start off with medical treatment. If the patient is missing dopamine, what do you give them? You give them a dopamine enhancer or a dopamine agonist. The 2 drugs of choice are bromocriptine and cabergoline. Now, bromocriptine is the one that's been studied the most. It's been studied for decades now. It has a worse side effect profile. It probably has been studied more. We know long-term what it does, but it has more side effects, nausea, vomiting, and stuff like that. And that's why some people prefer to use cabergoline instead. Now, cabergoline, though, has never been tried in people that are pregnant. We don't know what the outcomes are. We don't have enough data, so you have to be very careful in those patients that are pregnant or that are about to get pregnancy. Remember, one of the reasons to reverse galactorrhea, amenorrhea in young patients is for them to be able to get pregnant. So we start off with both of these drugs. Both of these drugs are dopamine agonists. Both of these drugs work very well. They suppress prolactin levels. And what's very important for you for the boards is that they also reduce the tumor size. So not only do they reduce prolactin levels, but they reduce tumor sizes. So that's why these drugs, we start from the beginning with medical treatment, pharmacologic treatment in patients with prolactinomas. If this doesn't work, especially if the patient's having a lot of pressure phenomena, I mean visual disturbances, visual field cuts and stuff like that, then you have 2 options: surgery and radiotherapy. But these 2 come later because both of these scenarios, both surgery and radiation, XRT, they have about 30% of panhypopituitarism. They cause, in 1/3 of the cases, panhypopituitarism. So you don't want to start off with these treatments unless you show that the dopamine agonists don't work or the patient's getting worse on the dopamine agonist. So remember that. Now, they ask us a question: which are the patients that are, we have to be aggressive about treating with prolactinomas, and that's the patients that are in childbearing age, because if you don't reverse that quickly, then it can't get pregnant. Older patients, older women that have small prolactinomas, well, sometimes, we could, be slow, very slow in the treatment and watch and wait and stuff like that. But the young patients, we have to be aggressive about. They may also ask us a question, the young women we have to be aggressive about. We also have to be aware of this, that I said it before, women generally have microadenomas, where men usually develop macroadenomas, and it's the men that usually develop the symptoms from the head, the nausea, the vomiting, the blurry vision, the visual field cuts. If they occur, they're going to usually occur in men. And they may ask a question, well, which are the patients that will eventually need a more aggressive form of treatment, surgery or XRT? And the answer is it's usually the men, because usually the men have the macroadenomas. So we exclude simple stuff in galactorrhea. After that, when we exclude pregnancy, drugs, and hypothyroidism, check prolactin levels. Once the prolactin levels are elevated, you've diagnosed the prolactinoma. This is the most common functioning adenoma of the pituitary. Get an MRI to visualize it. Start the treatment, usually with dopamine agonists. So let's go back to this case. A 32-year-old woman comes to your office because of milk-like discharge for over 4 weeks. Her examination reveals galactorrhea, but it otherwise is normal. What are the next most appropriate tests? We check a TSH, we get a good medication drug history, and we get a pregnancy test, and then we look at the prolactin level if all these are normal. Most people get all these at the same time, but they want you to exclude these things first. Now, the second disease of the anterior pituitary, where we have hyperfunctioning of an organ, hyperfunctioning of a hormone, I should say, is acromegaly. Now, in acromegaly, we have excessive growth hormone. So, you know, these patients, if they develop acromegaly, or they have the excessive growth hormone, I should say, when they're children, they develop into giants. They're over 7 feet tall and so forth, versus if they develop this when they're adults, and then usually their bone structure increases, but they don't, you know, they can't increase in size. Their arms change, their foot size changes, and this is referred to as acromegaly. So most of these, you know, compared to the prolactinomas, most of these, about 3/4 of them, are macroadenomas. This is an aggressive disease. Acromegaly is not a benign disease. You know, clinically we see the enlargement of the hands, the feet, the tongue, the mandible, right? Sometimes they tell us they need to change, you know, shoe size every year, you know, even though they're, you know, 50, 60 years of age. You know, in the olden days where people used to wear hats, one of the first things that these people saw is they used to see that they used to have to change hat size. Their tongue gets bigger and so forth. They develop not only enlargement of the bones and muscles and so forth, but they develop enlargement of the organs, and the most common cause of death in these patients is congestive heart failure. One of the common things that they like to ask us about is bilateral carpal tunnel syndrome. So if the bones and the muscles, you know, kind of grow, remember the medial nerve goes through this very tight area called the snuff box, right in the where the medial nerve passes through the wrist, and these patients commonly get bilateral carpal tunnel syndrome. The other endocrinopathy that develops bilateral carpal tunnel syndrome is hypothyroidism. So we always need to think about these two endocrinopathies when we see patients with bilateral carpal tunnel syndrome. Most patients get unilateral carpal tunnel syndrome because of the way they use their hands, and it's an overuse syndrome at work. They usually use one hand over the other, but patients with acromegaly and hypothyroidism develop bilateral carpal tunnel syndrome. Think of those when they tell you about bilateral carpal tunnel syndrome. A lot of these patients develop diabetes. Almost 80–90% of them have some kind of hyperglycemia, and about maybe a fifth or fourth of these patients develop diabetes, frank diabetes. Now remember, growth hormone is a counter-regulatory hormone. It acts like cortisol. It acts like epinephrine, norepinephrine, and glucagon, that it's a counter-regulatory hormone. It counter-regulates the effects of insulin. So these patients commonly develop diabetes. That's one of the things that we notice metabolically. They develop hemianopsia, where hemianopsia is rare. In patients with prolactinomas, it is common in patients with acromegaly because these are macroadenomas. What type of hemianopsia do they develop? The answer is it's close to the optic chiasm, and they develop bitemporal hemianopsia. So acromegaly, as I said, is a chronic disease. You have it 9 to 10 years before the diagnosis is considered. The diagnosis is made through two ways. If you remember your pathology and your pathophysiology a little bit, growth hormone doesn't directly affect tissues and organs. It works in the liver and it secretes these other factors called insulin-like growth factors, or IGFs. They are sometimes referred to as somatomedins. Somatomedins, mediators of somatic activities. So these insulin-like growth factors, these somatomedins, those are the ones that have a direct effect on the organs, on the bones, on the heart, and so forth. And these we can measure in the blood. And because growth hormone has tremendous diurnal variability, so in the morning it could be low, at night it could be high, in certain people it could be low, and certain people it could be higher. Because of this variability, the test to do to diagnose acromegaly is to measure these insulin-like growth factors, these somatomedins. This is the most reliable test. This test also is good for follow-up of disease. Once you put the patient on treatment, you say, they may ask a question, well, how do you follow disease activity? How do you know you're doing well? And the answer is you measure insulin-like growth factors. They were elevated, and then I put the patient on treatment. They should come down to normal if I'm doing well. A second test they sometimes ask about is this thing called the glucose load. We do that sometimes along with the insulin-like growth factor. They're going to ask you one of the two. They can't ask you both. If they ask you both, you're going to pick the insulin-like growth factor test. But the glucose load is based on the premise that if you give a patient glucose, a glucose load, you increase the glucose in their body. And once you increase the glucose in the body, the counter-regulatory hormones like growth factor, like growth hormone, like norepinephrine, like epinephrine, like cortisol, like glucagon, those should suppress, because if your glucose goes up in your body, the counter-regulatory hormones come down. Remember, the counter-regulatory hormones make your glucose go up even further, so you don't want that. They go down, they get suppressed. Your insulin goes up, but your counter-regulatory hormones go down. So what we do is we give the patient a glucose load, and then we measure growth hormone a couple of hours later. A normal response, a normal patient, the growth hormone would be suppressed. A patient with acromegaly, you give a glucose load, you measure growth hormone 2 hours later, it's still elevated. That's an inappropriate response, and that patient has acromegaly. The next test to do after you verified acromegaly with both of these tests, or one of these tests, the IGF are usually good enough now, we go into an imaging study. We go into an imaging study, and what's the best way to image the pituitary? The answer is an MRI of the pituitary, and now you localize it, right? And then you decide to treat it. Please be careful. They've asked questions about, somebody that has, looks like he or she's acromegalic, or they have galactorrhea, and they say, why don't we just go straight to an MRI and just look for a pituitary adenoma and then take care of it? The answer is because if you take 100 people off the street and you look in their pituitaries, in about 10% of these people you find adenomas that are non-functioning adenomas. So in order to be able to diagnose acromegaly or prolactinoma, some other type of pituitary disease, you have to show hormonally active disease and then localize it with the MRI. Please be careful. They've asked that question many times. Why don't you go straight to an imaging study? The answer is, I have to show that this is a hormonally active disease. That's the only way I could confirm it. If you don't confirm it that way, you can't do the MRI because it won't tell you anything. That's just for localization. Also, they may ask us the same question in the adrenals. We'll talk about that later. But bottom line is, in endocrinology, we only do imaging tests. We leave them for last. We have to show hormonally active disease before. So we did our MRI, we've diagnosed the disease, and now we go to treatment. The treatment of choice for acromegaly is considered octreotide. Octreotide is a somatostatin. So somatomedins are mediators of somatic activity. That's what the growth hormone does. Octreotide is a somatostatin. It stops somatic activity. It blocks, it downregulates growth hormone, and it shrinks the tumor size. Interestingly enough, bromocriptine could also be used here, and so could carbergeline, dopamine agonists. It seems that these tumors have dopamine receptors, and you could downregulate them with dopamine agonists. So if they don't give us octreotide, that's the first option. that's the drug of choice now. If they don't give us that, please look for dopamine agonists. If they ask a question, which pituitary tumors could dopamine agonists be used in? The answer is they could be used in prolactinomas and they could be used in acromegaly. I just told you about that. Again, just like in pituitary, in prolactinemia and prolactinomas, radiotherapy and surgery is left as the last option because it will cause hypopituitarism. Unfortunately, in acromegaly, it's used much more common because it's a more aggressive disease. Most of these adenomas are macroadenomas, so the last resort, radiotherapy or surgery in these patients, it's not so uncommon because it's an aggressive disease. But again, we start with octreotide first because that's a treatment of option. If they don't give us that, tell them we could use dopamine agonist, bromocriptine. We want to go a little bit and talk about, we talked about hyperfunction of the anterior pituitary, and now we want to talk a little bit about hypopituitarism in the anterior pituitary again. Now, anything that will cause a lesion in the pituitary hypothalamic region will do that. So you know, if they tell you the patient has TB in the brain or sarcoid in the brain or mass effect in the brain or after trauma, you could see hypopituitarism after all these, anything in that area, the pituitary hypothalamic region acts as anything affecting that area will affect and may cause hypopituitarism. Tuberculosis is common, sarcoidosis is common, tumors of the brain are common after trauma, abscesses. We see it in all these scenarios. If you see hypopituitarism in children, it's usually due to craniopharyngiomas, these very interesting tumors that are very treatable, but they usually occur in children. And I said tuberculosis and sarcoidosis is also common, especially in adult patients. It's usually not seen in children. Now, if we take all causes of hypopituitarism across the board, we'll notice one thing. We'll notice that the hormones that are lost early are the ones that are needed least in the adults. For example, the FSH, LH, and growth hormone are lost first. That's the way things go. So no matter what the cause is, across the board, the hormones that are lost first are the ones that are least important. They're important, but they won't kill the patient. And that's the gonadotropins, FSH and LH, and growth hormone. So if you tell me the patient has hypopituitarism, those are the hormones I'm going to check first because those are the ones that are lost early. After this, now we lose the more important ones, like TSH, and then the most important one, ACTH, that regulates adrenal function, that's the most important one, is lost last. So gonadotropins, GH first, then TSH, that's also important, right? And then last, the most important one that the pituitary loses is ACTH. That's the way things go. So if you're going to do a test, if you're going to test, you know, to diagnose hypopituitarism, you have to test for early hormones. Because if you check for ACTH, that may be not lost early. You may have hypopituitarism, but ACTH is still intact. So you have to look for those early hormones first. So the diagnosis is made by measuring gonadotropin levels, FSH, LH, and then measuring growth hormone levels after hypoglycemia. So remember the test that we did before, where we gave the patient a glucose load and we measured 2 hours later and we measured the growth hormone and we wanted it to be suppressed? Well, what if we do the opposite of that? What if we give the patient 5 units of insulin? This will cause the glucose to go down, maybe about 20 minutes to an hour later, right? At that time, we measure growth hormone, and what should the growth hormone do? If your sugars are low, remember, what do your counter-regulatory hormones do? They come up, right? They counter-regulate the effects of insulin. They make your sugar come up. These are very important hormones. If you lose your counter-regulatory hormones, you develop hypoglycemia. So we give the patient 5 units of insulin. We cause hypoglycemia. At the same time, we measure growth hormone level A normal person should have increase in growth hormone levels after induced hypoglycemia. A patient with hypopituitarism will have suppressed growth hormone levels despite the hypoglycemia induced by the insulin. So very important, how do we diagnose hypopituitarism? How do we diagnose it? We measure gonadotropin levels, and we measure growth hormone levels after induced hypoglycemia, induced after we give the patient insulin. So please remember that. This is in all cases. Now, once you induce hypoglycemia, right, you could also measure cortisol levels. So you can measure if the ACTH there is intact. But most important here is to measure growth hormone levels. So, two diseases that we have to know is pituitary apoplexy. That's probably the most important one that we have to know for the boards. And this is a very interesting disease because these patients usually have a history of a prior adenoma. Prior adenoma that's not well treated, or the patient got lost to follow-up. And what happens to the prior adenoma is that it expands, it starts to increase in size, and all of a sudden there's necrosis at the center and bleeding at the center of the adenoma. And what this basically does is it wipes out all of the pituitary. So this is acute hypopituitarism. Acute total hypopituitarism. As the adenoma grows, bleeding occurs in the center and wipes out the pituitary, and the patient presents with a very acute syndrome. And this is not chronic, this is acute. They present with confusion, headache, altered mental status. They usually have nuchal rigidity and meningeal signs. Now this is very important because they try to trick us on the boards. They give us a patient where, this guy's coming in with a stiff neck, vomiting, photophobia, mental status changes and stuff like that. And they want you to think this patient has meningitis, and they could have meningitis. But the trick is in the history. Somebody tells you from the family that the only history this guy's got is that he has got a pituitary adenoma in the past that wasn't treated well. He didn't follow up with his doctor. And then they tell you that they did a CAT scan of the head to exclude bleeding, and they found a bleeding in the pituitary. That's the second characteristic finding that they tell you about. And then they ask you, what is this likely to be? And your answer is going to be pituitary apoplexy. Now, pituitary apoplexy is a medical emergency. It's an endocrine emergency, so the patient has to be hospitalized. Definitely hospitalized, put in the intensive care unit. They give him a lot of replacement hormones, and they probably have to intubate him and so forth. You don't have to know all that stuff, but you have to know that this is an endocrine emergency. This patient has to come into the unit and stay in the unit until the patient's stable. So pituitary apoplexy occurs in the setting of an old adenoma, an expansion of an old adenoma with bleeding. The patient has acute pituitary dysfunction, meningeal signs, confusion, right, and so forth. So please remember that when you're evaluating patients with, that look like they have meningitis, viral meningitis or bacterial meningitis. Think about pituitary apoplexy also, especially if the patient has had an adenoma in the past. So the second syndrome we have to talk about as a form of hypopituitarism is Sheehan syndrome. You probably know about this already. It's common to see this with gynecologic cases because it usually occurs postpartum, and this is postpartum necrosis of the gland, likely associated with hypotension during pregnancy. So this syndrome usually evolves usually weeks or after pregnancy or months after pregnancy. The first thing that the patient notices or comes to us and complains is the inability to lactate. So think about Sheehan syndrome if the patient comes to you right after pregnancy and they tell you, I can't lactate and so forth. Sheehan syndrome, most of the time, as I said, is seen around pregnancy, weeks to months later, but can sometimes be seen years later after the pregnancy. Now, there's a lot of theories of why that happens, years later. But think about it, if it looks like typical Sheehan syndrome, think about it, even though it's not, the pregnancy has been, years before, a couple of years before, or something like that. Some people think that this type of Sheehan syndrome may be immune-mediated. So most of the cases around pregnancy, but sometimes we could see it a couple of years later. Think about Sheehan syndrome in that case also. I want to talk about one last scenario here. This syndrome does not cause hypopituitarism. It does not. It's called the empty cella syndrome, but I want to explain to you a couple things about the syndrome because it's commonly finds itself on the boards as a choice, and if we usually can't find the reason for another answer, we commonly choose empty cella syndrome because empty cella sounds like, you know, all the hormones would be ineffective and would be, you know, there's no pituitary there. But in fact, this syndrome, there is no hormonal problems with empty cella syndrome. Now, I'm showing you here with the arrow, I'm showing you a normal pituitary, and here's the anterior pituitary and so forth, something like that. And now what you could see is, you see this diaphragmatic membrane right here that basically keeps the dura and the arachnoid out. And now some of these patients, they have some problem with these diaphragmatic surfaces here. So what basically happens is, you could see now the meninges come in here. Look at this arrow, right? The meninges come in here, right here, the arachnoid, the dura, and what this does is it flattens out the pituitary, it pushes it off to the side here. There's still a pituitary here, right here. It's still working, it's still functional, but when you do the MRI, you can't see it there because you see the meninges and they're pushing off, they're squashing the pituitary off to the side, and the radiologist can't see it, so they tell you it's an empty cella. There's nothing in it. There is something in it, it's pushed off to the side. Now, these patients don't have any hormonal problems. I told you the pituitary is intact. So why did they get the CAT scan on the MRI? They got it for other reasons. They came into the emergency room complaining of headache, something else, or they got into an accident and somebody did a CAT scan or an MRI to make sure they didn't have any blood in their brain or any fractures in the brain or something like that, and they found this is an incidental finding. A patient with empty cella syndrome should have no hormonal problems. If a patient that is presented to you has any hormonal problems, pituitary problems, or anything like that, it's not empty cella syndrome because I just told you these patients have an intact pituitary. All they do is have those diaphragmatic membranes. They're missing those diaphragmatic membranes, so the meninges come into the cella. They push off the pituitary off to the side. That's all. That pituitary is still functioning. So that's the empty cella syndrome or empty cella, and it's commonly an incidental finding on an MRI or a CAT scan. And if you think about it, if we didn't do an MRI or CAT scan in that patient for some other reason, we would never know about this syndrome. So please remember that in case they give you that as a case or as a choice, don't be fooled. You know, if the patient is hormonally normal and they tell you this patient has an empty cella, could this be, you know, an empty cella syndrome? Yes, this could be an empty cella syndrome. And that concludes the diseases of the anterior pituitary.